Thank you, Dr. Fried, and a very apropos video. I feel like that wound would for sure get infected. So just a brief overview we'll talk about today. We'll kind of talk about why this matters at all, and then we'll have a little outlook as to how we got here. And then we'll review some big data sets and kind of landmark studies, and we'll make a verdict, and then we'll have some take-home points and clinical pearls. So why does this matter? Catheter line associated bloodstream infections that kill patients, it lengthens ICU stays, it drives healthcare costs up, and it's one of the few things we control. Among risk factors for infection, site choice is one of the few things we can do at bedside to assert some control. For decades, we've adopted the strategy of avoiding the groin where possible, but in the era of chlorhexidine, PrEP, ultrasound, and use of barrier precautions, we can assess, does that advice really make sense? So to answer that, let's see where the myth started. Oh, sorry, I'm just going through my notes. So in the 80s and 90s, studies did show that higher skin colonization around the groin and higher it showed higher skin colonization in the groin and also higher CLABSI rates. The problem is those studies are performed prior CHG, prior bundles, and often without sterile drapes or daily audits of catheter sites. And out of that came the mantra of avoid the groin. But like many medical myths, it may be more about outdated context than real hard data. So let's fast forward into the evidence that began challenging this data. So we start with Parienti in 2008 that was published in JAMA. And this was a multi-center RCT comparing femoral and jugular lines in terms of nosocomial events in over 750 ICU patients requiring renal replacement therapy. We can see that in terms of outcomes, there is a difference. Colonization objectively was different with 48.8 versus 35.7 incidences per 1,000 days, but the difference was not significant. And in terms of catheter-related bloodstream infections, there was a difference again on the objective data, 1.5 versus 2.3 per 1,000 days, but again, not statistically significant. The only signal was in obese patients, which was significant. And that was with regards to colonization. And these sites typically were colonized more the longer they were in place. So already back in 2008, the blanket statement of the femoral site is the dirty site. It starts to unravel. This is the graph examining different terciles in the data. And we can see that at a lower BMI tercile, there's actually there's more femoral lines that are free from colonization. But as both BMI and length of catheterization increase, we see that less femoral catheters were free from colonization, which is a roundabout way of saying that more femoral lines were colonized. So let's next look at a pooled analysis that tested the question even further. This was TIMSIT in 2013, published in ATS and American Journal of Respiratory and Critical Care Medicine. And this is a pooled analysis of 2 randomized trials involving ICU patients, over 2,100 patients and nearly 20,000 catheter days. We can see here that essentially throughout all major endpoints, catheter-related bloodstream infections, major catheter-related infections, and colonizations, there's no statistical difference between internal jugular or femoral lines. There is a statistically significant difference in some subsets. So in female patients and in patients with catheters applied over 4 days, the trend is towards IJ. And we can next look at the larger picture through a meta-analysis. So Merrick in 2012, this is a systematic review and meta-analysis of randomized and cohort studies comparing both femoral and internal jugular venous catheters. It was over 10 studies, or it's 10 studies, sorry, over 17,000 catheters and over 113,000 catheter days. And we can see here that early pooled data gave femoral lines nearly twice the infection risk. But when you strip out the 1990s studies and you focus on modern studies where infection bundles are implemented, the risk ratio shrank to 1.15 and it lost significance at a p-value of 0.52. So in short, aseptic technique improved the implied inferiority of femoral lines regarding infection disappeared. And in modern studies, there's no statistically significant difference in catheter-related bloodstream infections risk between femoral and IJ sites. The myth was really a relic of a pre-bundle era. So next came the heavy hitter trial. This was the NEJM 3 sites trial. This is a multi-center RCT, over 3,400 catheters, over 3,000 patients, and they're randomized to either subclavian, internal jugular, or femoral sites. And the primary composite outcome was catheter-related bloodstream infections or symptomatic DVT. So in terms of bloodstream infections, femoral versus IJ had a hazard ratio of 1.3, but it wasn't statistically significant. And although the bar chart looks impressive in terms of objective difference in the data, it's not something you can apply due to statistical significance. So we can look at these studies side by side and kind of see where things shook out. So we see basically in all data sets and all of these studies, there really isn't any significant difference in infection risk between femoral sites or IJ. So what is the verdict here? I would argue that this myth is busted. Across more than 2,000 catheters, femoral and IJ sites have no significant infection difference and when bundles are used. And 2 decades of data show that what once looked like an anatomical issue was really more procedural. As our technique improved, the infection gap disappeared. So I think the next time someone says avoid the groin, you can tell them the data disagrees here. The femoral site, it's not inherently riskier. It's really about how we place the line and then how we care for it. So some clinical pearls, what I take away from this as a resident. Technique is the larger factor here rather than site specifically. The infection risk really comes from sloppy prep, not from the site itself. Also, dwell time matters. Anything over 7 days increases risk no matter where it's placed. You can consider patient factors when placing a line. Obesity favors IJ. If you have a coagulopathic patient, you really need a compressible site, and that's either IJ or femoral. Subclavian objectively in the data is the cleanest, but it's the least forgiving mechanically as it can't be compressed. And femoral is still a great option for emergencies or when the neck access isn't safe. I think IJ is a great line. It's easily visualized. It's great for teaching. You can compress it. So, like, when is femoral a reasonable choice? It's acceptable when you can't use IJ or when you can't do a subclavian. If you have coagulopathy, neck trauma, cervical collars, or you're using a high PEEP ventilation strategy. It's compressible, it's quick, it's safe. If you follow the bundle using ultrasound, chlorhexidine prep, and full barrier precautions, and then remove it early, it's totally reasonable to do.
Great. Any comments or Questions? Nobody? Nurses in the back have any comments? I'm not aware of any recent data showing that dialysis catheters, femoral dialysis catheters, get infected more commonly. You're talking about CRRT. Okay, so maybe CRRT, that might be true. I don't know, but I don't think it's true of hemodialysis, intermittent hemodialysis, given in the ICU. We've also done, if anybody wants to look at it, last year we did one of the issues has always been mobility and being able to sit people up and getting up into a chair with a femoral catheter, and we did a Mythbusters on that, and there's really no data that it's unsafe or that it has increased complications of mobilizing patients with femoral catheters. So you might want to take a look at that. It's on YouTube if you weren't here for it. So I think that this is clearly much overblown, and even the risks that he showed are for colonization in females and obese patients more than it didn't, I don't think, demonstrate bloodstream and increased bloodstream infections even in those groups. So, and colonization is not really infection. We have a lot of catheters that can lead to catheter bloodstream infections, but it's not considered a bloodstream infection. So I think, like he said, the key is to use sterile technique. The biopatches have also shown the chlorhexidine biopatches have shown additional benefit to decreasing the risks. And I think when we use these kind of sterile aseptic techniques, sterile precautions, chlorhexidine, it's infection-wise, it's safe to do femoral catheters. And I think probably historically we haven't done them because of that perceived increased risk, as well as maybe some of these other ideas that you can't mobilize patients. And I think a lot of those fears were unfounded. And maybe we should be doing more of these in the future. I think certainly if you're having any difficulty putting in an IJA catheter, or there's any other reason not to do it, femoral site is certainly reasonable, and especially if it's just for a few days. I think if it's going to be for less than 5 days that you're going to have the catheter in, it's probably fine. Okay, that's just my opinion, unbiased opinion. All right, so it's time to vote. Femoral CVCs have a significantly higher infection risk than IJ CVCs. And by infection risk, we mean CLABSIs, central line associated bloodstream infections. How many think this is true? How many think it's plausible? And how many think that it's busted? Looks pretty unanimous too. Okay. Just click.